Good afternoon, and thank you for having me here. I'm aware that this is a Saturday afternoon right after lunch, and I could give a lecture. And you're all spread out, and I could give a very technical lecture, but what I'd much rather do on this Saturday afternoon after lunch is teach. And I hope to teach you some basic concepts and have you cross the threshold out of this room remembering those concepts and able to call them to mind when you leave. Now let's see if I can advance the slides here. Yes. Okay. Good. I can walk in advance. So I call this Taming the Dragon. We're going to talk about malignant bowel obstruction, and I call this Taming the Dragon because I can think of the GI tract as a dragon, and I can think of the syndrome of the bowel obstruction as a dragon, with a head and a body and a tail. And in this case, the tail wags the dragon. So more about that in a second. But first, as we know, it's all about the patients. So let's start with Charles. Charles is a composite of several patients that we have had at Legacy Hospice in Hopewell House. Hopewell House is our inpatient hospice center. But the concepts I'm going to teach you today could be used anywhere. You can use them in a hospice center. You can use them in a palliative care patient. I'm going to focus on medical management because there are probably not many surgeons in the room. But we need to know when to think about surgery and when the patients might benefit from that and when they might not. So Charles is a 72-year-old fellow. He's a very nice man. He came in with his wife, and his adult daughter also visited. And he was referred to us for intractable nausea and vomiting. And he had achy pain, the head of the dragon. And he had abdominal distension and colic and hiccups and belching. And he had not had a bowel movement in 9 days. He'd been at home. And everyone thought that they were keeping track of the bowel movements, but they weren't. So it had been 9 days. And where I come from, 3 days is the max. If you go to 3 days, you need to be rescued. Call the SWAT team. So this fellow was in a world of hurt. And when I took a look at him, he had positive bowel sounds, but they were very high-pitched and tinkling, classic medical school stuff. His abdomen was tense. You could bounce a quarter off of it, kind of tense. And he had no stool in the vault. And in fact, his rectal vault ballooned out around the finger, the examining finger, rather than fitting like a glove. Okay? So he came for nausea and vomiting. Lots of these patients get referred or get thought of as a nausea and vomiting patient. And you have to think about all the causes of nausea and vomiting. As you can see on the slide, you can group them into 3 basic groups. We could talk more about nausea and vomiting later today, but the referring physician had a high pretest probability for constipation, obstipation, or obstruction, and so did we. So we're going to focus on those 2 areas. So when you have a patient who you're concerned about malignant bowel obstruction or constipation, you want to check for adherence to the bowel regimen. Had they stopped taking the Senna? Had it caused some cramps and the wife stopped doing it? Was there a massive bowel movement and they decided they didn't want to have bowel movements that often? Right? Stop any offending medications and substances. Lots of colon cancer patients are put on iron. Very constipating. Stop the iron. Change the opioids to something less constipating. Consider, if it's appropriate, consider doing some labs for hypothyroidism. All right? If you haven't diagnosed something like colon cancer and you have these symptoms, consider doing some labs for colon cancer. At least look for iron deficiency. Examine and assess the patient for volume. Do some labs for volume status to see if you're going to give hydration or not. If you think imaging is appropriate, start with x-rays. All right, do a flat plate, do left lateral decube, something like that. Do a KUB, see if there are any air fluid levels. If surgery might be an option, and the patient's functional status is high enough for it, consider doing imaging beyond that to really look at the anatomy closely. For hospice and palliative patients, though, typically we start by treating the reversible causes. And the first thing to do anytime you suspect obstruction is to try to treat for pseudo-obstruction. Try treating for constipation or obstipation. I can't tell you how many times we've gotten patients referred to us for complete malignant bowel obstruction who actually are constipated and obstipated. And we do a bowel rescue and they get better. It's great. I feel great when that happens, okay? So if you're worried about obstruction, try treating to see if you can get the bowels moving again and start from below. If it's appropriate, give a little hydration to tide the patient over and try for at least 24 hours. The literature suggests 24 hours of trial. I'll tell you, I have gone as high as 48 hours. But try to get things moving from below with your rescue protocol. If there's stool in the vault, start with a bicicotal suppository. If there's no stool in the vault, start with a Fleet's enema and go from there. Try not to have to do anything from above in case there is a complete obstruction. You'll end up with a very crampy, painful, unhappy patient. Don't use any promotility agents if you suspect obstruction. So Charles was lucky. We treated him for this pseudo-obstruction, and he got better. He had that ballooning rectal vault. We did not use a bicicotal suppository because the vault was empty, and so we went to the Fleet's enema. We treated his nausea and vomiting with haloperidol and diphenhydramine, and we changed his hydromorphone to methadone because methadone is less constipating than hydromorphone. Even though he was obstructed and not really swallowing well, he was able to take the sublingual methadone. It's rapidly absorbed under the tongue, and his pain was controlled that way. He had laxation. He started eating and drinking. We put him on a low-residue diet, and we started a maintenance of senosides and sorbitol, titrated to keep his stool like mayonnaise because we suspected he was impending obstruction. He did well for several weeks, and so this was a great outcome for us because he had some good quality of life with his wife. And then it came to our attention that he'd had no bowel movement for 4 days, despite a rescue of his bowels on our protocol. We have a particular protocol in our hospice that's graduating maintenance levels with as-needed rescue. He had, again, achy pain, the head of the dragon. He had abdominal distension, colic, hiccups, eructation, so gas moving around, right? And he had nausea and vomiting, the tail that wags the dragon. He had those high-pitched, tinkling, tense bowel sounds and nothing. Trade me.
This one's humming.
Oh, thank you. Oh, maybe I'll stay away from speakers too, but yes, that's better. Thank you. So, this time we're thinking about malignant bowel obstruction again. And we want to at least think about surgical options, because for some palliative and hospice patients, we might consider that. So what do we think about? We think about whether debulking and reanastomosis would be good. We think about whether a diverting ostomy would be okay. We think about whether a stent would be appropriate, or whether just putting in a percutaneous venting gastric tube would be good. So there's lots of literature comparing surgery versus stenting, and here are some of the statistics on that. Higher, okay, thank you. So surgery versus stenting, here are some statistics. They both improve symptoms to varying degrees. And when you look at these, don't think that surgery might be better than stenting. Realize that one of the big influencing factors is where the lesions, where the obstruction is. That plays into the success rates of these two. So stenting has a good success rate, but it tends to be for left-sided obstruction, something that's easy for scopes to reach to place the stents. The obstructions that surgery is intended for are more difficult to manage, so the statistics aren't great, but the references are in your slides. 30-day mortality is lower in stenting. Complications are all over the map. And surgery, it's pretty clear, is best for patients who have a greater than 6-month prognosis. So it would be a very unusual hospice patient who would be appropriate for this kind of surgery. And high functional status is best for surgery. Also note, related to surgery for malignant bowel obstruction, symptoms are relieved, and success was deemed only 1 to 2 bouts of nausea and vomiting a day. You would think that you would consider surgery no nausea and vomiting, but that's not true. Some nausea and vomiting is expected after surgery or stenting. Patients can eat again. There's a fair amount of discharge home. There is some morbidity and mortality, but look at how much hospitalization consumed of the rest of the patient's life. 11 to 61% of their remaining life was consumed by being in the hospital. So your patients need to know that in advance. So, surgery. Are we going to do this? I'm a hospice doc. I have done palliative care in the hospitals. I've done upstream palliative care. I haven't referred my patients for a lot of surgery because I talk to them about the kind of medical life that they would have with the surgery. And a lot of them are worried about it because it's very hard to predict how much life they have left. And so it's a cost-benefit analysis that they're doing. But some patients really like it, and they can resume a better life. Literature says that palliative surgery does increase life expectancy in women with ovarian cancer and carcinomatosis. But other folks with carcinomatosis, it doesn't do well with. All right? It doesn't do well with multifocal obstruction. Stenting wouldn't work in either of these very well either. If there's a lot of ascites, surgery and stenting aren't going to be good. And if there's poor nutritional status reflected in low albumin, if there's lots of inflammation reflected in leukocytosis, high white count, you wouldn't want to do it. The results aren't as good. And if the stage 4 of the cancer was diagnosed at an earlier time than the obstruction appears, it tends to bode worse in terms of outcomes. If this obstruction is the first evidence of stage 4 disease, it tends to do better. Okay? So, back to Charles. Charles, his stage 4 disease had already been diagnosed weeks to months earlier. That's not good. He had carcinomatosis. That's not good. He had very poor PO intake. He'd been eating, but his appetite wasn't very good. I can't say that he had anorexia cachexia, but I suspect it. He was obese. He was a very large man, but he was not eating well. And he lived in the triangle. That's what we call it. Bed to bath to chair, living in the triangle. We use that a lot for functional status in hospice. So, thinking about medical management then. Pain, the head of the dragon. Distension, all the gassy distension because the bowels don't move, and nausea and vomiting. So pain. Pain comes from inflammation, it comes from edema, it comes from the tumor itself. And so we tend to use opioids for that cancer pain, and we use steroids. In hospice, we often use dexamethasone. It doesn't have as much bloating associated with it as prednisone does. It's relatively inexpensive. You can use it once a day or more than that. The distension is felt as symptoms like the cramping, the extra GI secretions, hiccups commonly. And so we have to address these symptoms usually in one of 3 ways. And here's how I explain it to the patients. You can take small sips of fluid, drink liquids, and we'll give you some medicine for the symptoms of cramping and gas and all of that. And you can expect to vomit once or twice a day. You can have a tube to drain your stomach, and we can put that tube down through the nose, at least temporarily, or we can put it in through the stomach. And you can drink as much liquid as you want, liquids that don't clot, like cow's milk will clot in acid, and so then it wouldn't be able to drain out the tube. But you can drink any liquid that will drain out of that tube. Or we can turn off your GI tract, and you don't have to have a tube, right? And you can take some tiny sips. And to the extent that you're eating and drinking, you may vomit or not. Some people might have some absorption. If the obstruction is low down, then they might have some absorption of liquids. And that can increase their survival time. So I'll tell you, a lot of my patients actually opt for having an NG tube and drinking ad lib and trying to vary tastes and flavors that way and dealing with the dry mouth that way. We will often use glycopyrrolate injection. Scopolamine is one that's talked about a lot, but elderly people get delirious on scopolamine because it crosses the blood-brain barrier. And so if you're going to manage someone for a long time with scopolamine, think about that in the elderly. Glycopyrrolate does not cross the blood-brain barrier. It comes in oral and injectable forms, and it's great for these symptoms. I found it very good for the hiccups of bowel obstruction. It's not generally a hiccup medicine, but for the hiccups of bowel obstruction, I've had good success with it. Octreotide is very expensive. You will not see hospices using it that much. And it used in the proper dose, either Q8 dosing by injection, IV or sub-Q, or with an infusion, or a depot injection. You can shut down the entire bowel tract. If you're going to use a venting gastric tube, you don't need to use octreotide. Don't use both. All right? The venting tube is going to take care of letting everything escape from the system. But you don't need to both place a tube and pay for octreotide. So one of those options. And then the tail that wags the dragon, the nausea and vomiting. In treating vomiting, you have to think about two things. You have to think about how to turn off the chemoreceptor trigger zone in the floor of the fourth ventricle up in the brain. That's one place that medicines are active to stop the nausea. And you have to think about the vomiting center. Now, I'd say in 60 or 70% of patients, treating just one of those parts of the brain will work for your nausea and vomiting. It depends on what the cause of the nausea is, but we can talk about that later today. So pick something that will work for nausea, something cost-effective with a low side effect profile, especially in your elderly patients, and consider whether or not hydration is important. If you're tiding someone over or they've been dehydrated from vomiting, it's nice to give IV or sub-Q fluids. Sub-Q is easy to give in a hospice setting. But those are the three things: the head and the body and the tail. So basically, it's like a cocktail that you have some options for in each category. And the trick then is to remember the three categories for managing the symptoms. So Charles, he had his recurrent symptoms, so we felt it was complete obstruction from his cancer, and we used injection hydromorphone with a CAD pump. Other options would have been transdermal fentanyl or methadone given sublingually, gastrically, or rectally. And we added the IV dexamethasone, and the literature recommends 4 times a day. So 4 milligrams 4 times a day IV. You can crush it and slurry it under the tongue if you're in a home setting. You can see if that will work adequately. For his distension, we put an NG tube in and set it up to low intermittent suction. We considered a gastric venting tube, but he did not want to go to the hospital. So we kept that NG tube in and babied it along and did the best we could with it until we took it out because it was irritating. And he was able to freely take liquids, and he was satisfied with that. He did not have any nausea and vomiting because that NG tube was working well. We used the glycopyrrolate as our anticholinergic because he was elderly, and he did very well with that. He had really extensive hiccups, and it stopped his hiccups. Scopolamine would have been another option, or hyoscyamine. And nausea and vomiting, we chose haloperidol with PRN dose, scheduled and PRN dosing. We started with diphenhydramine PRN and then went to scheduled diphenhydramine for better nausea control, and it worked very well. The Haldol was set up to work in the chemoreceptor trigger zone, and the diphenhydramine works in the vomiting center to treat the nausea. So that's it. That's the framework. So that's the concept, thinking about managing malignant bowel obstruction. If surgery is right for your patient, go ahead and do that. If medical management is right, think about the 3 different categories of symptoms: the head, the body, and the tail of the dragon: pain, distension, and nausea and vomiting. And choose something to treat symptoms in each of those 3 categories all at once, and then make adjustments as you need, because you've got choices in each category. Thank you.